All right, so everybody should be seeing title screen of Principles in Practice, 5th edition, Chapter 5, Geriatrics, with that. So let's talk about what it is to get old. So when we talk about geriatrics, we have to talk about the general aging process. What happens, and the general term is covered a lot of times in the phrase human growth and development, where we start looking at some things. But again, as we get older, we get a general and a gradual decline in overall biofunctions. And again, those are from thinking more clearly, our reactionary time, being able to read things from smaller and smaller font, pretty much everything that you think about as you get older. According to the science, biological peak is before the age of 30. Typically, we see after that, things start to go down, things start hurting. So some of you that are approaching that 30 age group, please note that things are going to hurt a little bit more. If you listen to Bowling for Soup, remember after age 30, the hangovers do get a little bit worse. But that's something to think of, as well as functional losses. People can't walk well, things break easier, nutritional factors. But again, these are all normal. We are seeing the mean age of elderly people getting older and older as people live on, but also as a country in the United States, our healthcare costs are huge related to our gross domestic product, which is a way that we measure things on our healthcare costs. We spend close to $10,000 a year on individuals as they get older, and especially in the geriatric community, especially with end of life decisions, typically we'll see a third of that total money being spent in the last 3 months of life in life sustaining medicine. So that's something that we're going to see as we move along. And then we'll also see, because as the immune system drops down, everything else like that, we're going to start seeing more and more disease states in these people. So one of the things here down at the bottom of the screen here, you should see a natural progression of an elderly person here. Steve Rogers, if you're a fan of the MCU, we've got young Captain America and we've got old Captain America. What happened? And that's what we're going to talk about, is that transition from in your 20s and your 30s by the time you get to your 70s. It's estimated, they estimated that Steve Rogers in this picture here was about 74 years old with that. But why are people getting older? Well, one, we're living longer. All right. And population is going up. People are having more babies in certain time frames. But as we're living longer, why are we living longer? Well, people 65 years or older, in 2014, we had greater than 45 million. In 2019, it's estimated that we have a total of 46 million. Now, this is just in the United States. This is not worldwide. In the United States, as of 2018, they estimate that 337,000 people are age 95 or older. We'll see new numbers here in the next 2 years after the census is done, and they'll find out what those new numbers are. And with the whole census issue, we may actually see that number go up a lot more, especially with the influx of immigrants into the country. Between 2020 and 2030, we're expecting that the number of older individuals, and again, notice this is within that census time, we're expecting this 46 million to increase by almost 18 to 20 million. A lot of old people, and that's why you'll see that it's one of the largest growing areas of medicine. How do we take care of, by 2050, total of 90 million people? That's a huge number. All right. So why? Well, mean survival is increasing. The birth rate is declining as we get older, but those baby boomers that were born post World War II and pre like 68, they're starting to hit those numbers. I mean, I was born in 71. I'm 48. In the next 7 years, I'm going to be over that 55, which is the general term when we start looking at comorbid numbers according to NEMSIS, greater than age 55. Now, the time that we see this greater influx, again, is really drawn with the post-World War II, because during that time, 70 to 85 million worldwide died. in that time frame, we see that the U.S. lost about 1 million people during that time frame, and that 70 to 85 million worldwide casualties is civilian and military deaths, which was approximately 3% of the population, which was estimated at that time to be 2.3 billion. So after World War II, all those individuals came back and they started the American dream, which means they started having babies, and that's this population that we're seeing now. And we're giving more and more these living longer. The birth rate is not keeping up with the death rate. And again, the death rate is starting to slow. Now, again, the current pandemic is going to change that a little bit when we look back in 5-7 years on this. You know, where I think the United States is looking at what, 10,000 deaths, or I haven't looked at the numbers today. 10,000, I think that's worldwide with that. Vietnam, again, we saw an influx post-Vietnam area with individuals coming back from war. Estimated 3.3 million people worldwide died for that. In the United States, we saw a casualty death rate of about 211,000. So what has gotten better since World War II? Well, World War II, United States technology, all right, pharmacology. Looking at the amount of drugs that you guys have to learn right now, that is a huge number when it comes to how many drugs are out there that we're able to take care of what was once lethal diseases. Now we're able to give medications as well as the general technology of treating things. Back in the 1970s, late 50s, 60s, and 70s, if you had a heart attack and you went to the hospital, you were in the hospital for 3 to 4 months, and typically you went home and you were known as what was known as, you know, it was not politically correct now, but you were known as a cardiac vegetable. You couldn't do anything. So your quality of life went down, your length of life possibly remained the same, but with that quality also decreases the quantity. But with that, now we need PCI. We talk about medications, non-surgical treatments. All of that stuff adds on and adds into the general length of life. Now, if you were to sit down and compare the U.S. healthcare system versus, let's say, the Asian, specifically Japan or something like that, you would find out that individuals, the actual population, actually take care of themselves much better than we as U.S. citizens do. The U.S. has one of the highest rates of obesity, childhood obesity, as well as type 2 diabetes. We have horrible diets, and that comes along with, you know, the richness of our culture. We have access to food 24/7. Some of these cultures don't, or they live on very high fiber, high protein, low, lipoproteins. So that they live a healthier lifestyle. They walk, they ride bikes. We get in our car. Nowadays, sitting at the computer, I don't know about you, but I drove for 5.5 hours today. I've been sitting at a computer for the last 3. So that adds to the overall, illness rate. Couple of things, words that you need to be aware of. Gerontology is the study of aging, the effects of aging on humans. Gerontologists are those individuals that are specialists in treating the elderly. And then when we start talking about geriatrics, that specializes in the care of elderly. And when we look at the NEMSIS numbers, okay, 36% of all calls daily involve the elderly. Now, according to some statistics, if you look at it, they say elderly is 65 or older. A lot of times you have to look into that number to actually see. Pennsylvania starts aging people out, elderly or individuals with comorbidities, at age 55. But again, typically for the general consensus is anybody over 65, which is retirement age. But again, what are we going to do as the general elderly population gets older? Are we going to increase the age of retirement? Anybody have any questions at this point? Okay, so some issues, societal issues that deal with the elderly and generally getting older. Remember that usually when someone retires, anything after that, it's approximately 1/4 of their lifespan from retirement age. If someone was lucky, they hit the lottery, they won on their scratch-offs, they were able to invest, that may be even longer. But what we look at is this 1/4 lifespan when we start looking at when we actually start looking at what is known as HG&D, our human growth and development phases. Typically, human growth and development is broken down into three distinct areas. The time that you were born to age of 18, that's usually your growth phase. That's where you learn how to do things, interact with society, where you learn a trade or something like that. From the age of 18 to 65, that's where we mature. And again, there's a peak. And again, if we end up looking at a traditional bell curve, that 18 to 65, typically when we see in the United States, typically we see around that 40 to 45 when we look at the maturation, where at 40, you know, by the time you get into your mid 30s, you've got a career, you're starting to save money, you started having kids, you started paying off all your student loans, all that other stuff. And then on the back end after 40, that's when you start preparing hopefully for retirement. And then after that is 65, and you start living off hopefully what you saved in the back there. Now in the United States, we have some monetary assistance when we look at the elderly, you know, Social Security and everything else like that, which you pay into up until you're age 65, and then you can actually start withdrawing from that without any tax penalties. But what we're actually seeing on a national level, because everybody's getting older, as well as we've introduced individuals from the economic standpoint, individuals who've not paid into that system, we're actually losing a lot more than that's there. But again, that's something, that's why they push all of that self savings onto the individual with 401k and being able to provide a lifestyle after retirement. Now, during this time, we have those transitions where we have a reduced income individuals, these geriatric community, where they were making $100,000 a year, and now they have to go to a fixed income budget, where now instead of bringing in $100,000, they're living off $60,000. You know, they move to warmer climates, stuff like that. So a lot of this really depends on where you live and work as a medic, on whether or not you have a high volume of elderly versus a lower volume as we go down. Other things that go on, the relocation. Again, as I just said, they could move to Arizona, they could move to West Palm Beach, you know, somewhere where it's warm, and they have a higher amount of like-minded individuals that are geriatric, that like eating dinner at 4 o'clock in the afternoon. The Golden Corral is their local place where they do get together and play bingo. Also during this time, we do have a lot of death. By the time they reach this age, you'll see that life, instead of giving you things, starts to take things away. They start losing a lot of their friends, family members, spouse, or their partner. And when they lose their spouse and or partner, they also lose half of their income, because if they are on retirement or SSI or something like that, that money then reverts back to the government. So that's something to be mindful of when you start taking care of these people. The majority of them are on fixed incomes. People get old too. They don't like, maybe there are some people that don't like being called an old person. Maybe they don't like to reach out for assistance. That's something to think about as well. As well as, because of that, there may be this sense of isolation or uselessness as one gets older. I'm sure everybody here can remember their grandma or their grandfather as they got older. Were they still active in the community? Did they just go and sit in their favorite chair? Did they do this or did they do that? Or were they active? As well as a lot of different cultures interact with their elderly as different than other cultures. Typically in the United States, we tend to institutionalize our elders somewhere along the way. I know with the Chinese, they tend to revere their elderly much, much more. That's why you'll see, especially now with the current COVID-19 pandemic, a lot of the elderly survived in China because they gave the extra effort for those elderly to survive, because they are revered in their culture more so than they are here, perhaps. We all are very aware of what is in our service area regarding elderly, independent, dependent living. Remember that half of those that are age 85 or older live by themselves. 78% of those 85 or older are women. Men die sooner. The old joke is we die because we want to. But, you know, you will find that. And I know in my immediate family, my father died first. and my wife's grandfather, both grandfathers, husbands died first. So we see a lot more women living on, and that can be attributed to women tend to take care of themselves a lot better than the men do. With that, we can also see a bunch of the elderly living alone, and because of that, impoverished and vulnerable. My wife's grandmother, up until 10 years ago, at the age of 79, lived on a farm and took care of 5 acres by herself. It took a lot to get her to move into the personal care home. But stubbornness comes into that as well. And again, as I said earlier, the death of the partner and or spouse reduces overall income, pensions, SSI. And again, low income forces elderly to choose among basic necessities, whether that be heat, whether that be food, medical care, pharmacy, transportation, being able to get anywhere, rent, mortgage, all those things that we think about are all true to the elderly. Depression, mental health in the elderly is very, very common. But there is a 90% who live alone do choose to maintain their overall independence. Up until the point where somebody has to put their foot down and say, nope, you can't do this anymore. You got to be able to move on. But again, if we look beyond just their chief complaint, most elderly don't complain that much. They'll tell you, yeah, my son's helping me, my daughter's helping me, I've got everything. Just let's figure this out. And you being the good medic and assessing your patient, you're not you're not in social services, but to get an idea and to document that and to be able to help individuals navigate and be an advocate for those patients, get them some help. But again, 74% of the elderly, according to these statistics, which again was these are all drawn from 2010 Census Bureau, 74% receive no assistance, 43 rely on paid assistance, 54% unpaid assistance, family members, everything else like that. 3% use both types of help from either family or paid assistance. And of that, 5% live in nursing homes. And I expect that number right there to be going up. And the other thing is, isolating, and we're finding this out now with the pandemic, is social distancing and social isolation is helping flatten the curve. But for the elderly that need to be isolated, please note that without that social network, a lot of people, elderly especially, get down into some social disorders and mental health issues that may build on top of their already frail medical health. Now, as we go through this, there's a lot of pictures here I'm going to show you that I'm going to draw on from my own personal experience over the last 5-7 years with my father dying as acutely and my mother succumbing to COPD and cancer over a 5-year period. Because one of these things here, and I know I'll hear you all laugh, okay? But what are the dependent care arrangements that these elderly people are getting taken care of? Is there live-in nursing? I'll tell you what, that's very, very, very expensive. We looked into that with my mom. We looked at assisted living. My mother was very, very, very adamant she wasn't going to no damn nursing home. So we had to try to keep her wishes. Trying to put them into, getting my mom social aspects. Towards the end of the last year of her life, my mom was on 32 liters of oxygen, which blew the respiratory therapists away. She actually had 3 concentrators piggybacked. And that was just to keep her SATs at 88%. Congregate care, where we get together once a day. Are there personal care homes? Or what we end up seeing is a European model of these where we end up depending on family. And we see this, human growth and development this through the ages. I've got some different pictures here. This is circa 1985, 1986. My daughter was looking at these the other days and she goes, Dad, you have the haircut just like that tiger guy. And I thanked her for it. But this is, my parents were in their mid 40s at this point. I was 17 years old. This is my sister Christine. She's 2 years younger than me. This is my sister Carrie Ann. She's 42, 7 years younger than me. And this is Dana, and Dana's 13 years younger than me. When my parents got older, we all had to chip in. My sister Christine ended up taking the brunt of it, because she ended up living with my mom most of the time. All the grandkids here assisted with that, but it was very difficult. And sometimes you may be called to the assistance of the family just for respite care. They don't know what else to do, or the family, maybe the moms and dads and the elderly don't have someone to call. But again, through the years, here we see 85. This is 2009, with all the grandkids at that time. And all of these kids now are, much older, and they all came in and it helped. This is my dad the year before he died. He was 65. He died at 66, secondary to a massive cerebral hemorrhage. Stroked out on a Monday and died on the following Sunday. Quick, short, to the point. 5 years later, my mom succumbed to 4 bouts of lung cancer and eventually COPD. With that, she basically suffocated to death. And my job was to go over. It was a family thing because of my travel. I went over every Sunday and made my mom a gourmet meal, which she hated every time. But you'll see that, and you'll get called into those situations. But there are individuals that may not have as a robust family as we did with this. As we get older, and again, if you don't have family members keeping up and keeping track of people, please realize that the elderly have a greater risk of accidental hypothermia. In the middle of July, a cold snap comes up, they fall asleep, they fall, they end up laying on the floor, accidental hypothermia. Or in the wintertime, individuals can't afford to keep their heat up, or something goes on, they get really, really cold. Carbon monoxide poisoning, very common. Flu-like symptoms in that time. My grandmother was great for this. Didn't think it was good to turn the boiler on, so she'd heat the house with the oven, with the stove and the oven, with propane and natural gas being given off. That then leads to fires. A lot of this elderly population also are smokers, falling in bed, falling asleep, something like that. Individuals also are at a greater risk of reducing their medication or halving their dose to save money. As well as many states have few or no restrictions on personal care aides, meaning individuals can just be brought in. There are individuals that will come in and take care of a loved one for $5, $7 an hour under the table, and those individuals basically con and or abuse those individuals. So it's a very black gray market when it comes to personal care issue like that. I know my one sister Chrissy does that on the side. She'll stay and take care of people at night. As people get older, they're much, much more aware of their impending mortality. So they're very well aware. I know a couple years ago, Grandma Ruth, my wife's grandma, is 95 now, and she came to us and asked, how do I get this DNR thing that everybody's talking about? So needless to say, my in-laws were not happy that we provided Grandma Ruth with a DNR form, but she comes in, they come into the the nursing home, personal care home, and she's laying on the floor. Ruth doesn't want it. We even legally went and explored having "Do Not Resuscitate" tattooed on her chest. She wasn't real big into that, but we thought it was a cool idea that 95-year-old Grandma Ruth was going to have a tattoo that said "Don't resuscitate me." Other things that we come into, and I'm going to be sharing, I just scanned it in. I'm going to scan you guys in a pamphlet. It's called What's the Patient's Code Status? It's a book that was written back in 2000 by Dr. Fred Mariachi, who was a resident at one of the hospitals I used to work at, and now he's the medical director for UPMC Hammett's ER. And it's a very informative book looking at DNRs and living wills and all that other stuff. Because at this point, us showing up at the scene can be very, very difficult. We show up, we as family believe we're doing what's in mom and dad's, grandma and grandpa's best interest. But please remember, these individuals still have a right to choose to have treatments and or deny treatments. That's something to remember, that, just because somebody says something, you always should check. Unless somebody has a medical power of attorney or a full POA, power of attorney, that individual still has a right to accept transport or whatnot. And it can become a very contentious moment for you as you try to figure out what's in the patient's best interest. Honestly, right now, in today's society with the COVID-19, if somebody's just going to the hospital for a cath insertion or something like that, hey, can't we get somebody to come in and do this? Let's not let these people get outside, because these low immunosuppressed individuals, excuse me, end up becoming infected. So it's problematic. Trying to figure out what's going on with DNRs, living wills, do not resuscitate orders is a quagmire. We have 20 minutes on scene to try to figure this out. We have to do what's in the patient's best interest, and as well as meet the needs of our service as well. All right.
Rick, quick question.
Yeah, who's this?
Sam.
Okay, Sam. I don't. Oh, there we go. Okay, cool.
So in regards to the DNR, I've heard various different things. I've heard that you have to have the Pennsylvania state DNR form for it to be legitimate legally. I know it, the nursing homes that we service in my area, there are nursing home specific ones, there are Philadelphia specific ones, there are ones that people get offline. When it comes to legalities and what's just easier for the family, where do we fall? Like, what do we have to do? Like, what do we follow? Is it definitively the state form? Is it anything as long as there is a power of attorney? How does that work?
Sam, I wish I could give you a concrete answer, but I can't. What I will tell you is this is a clinical decision that you have to make. Honestly, your best assistance is getting on the phone with your medical command physician and discussing it with them. Years ago, and I say years ago, this is when I was active as a medic, we used to have this nursing home that would just was the disdain of everyone getting a call there. Early on, it was you had to have the original. You have to have the original. You couldn't have a photocopy of a photocopy. Well, where are the originals kept? Well, they're kept in the director of nursing's office, under lock and key. Well, it's 3 o'clock in the morning. Okay, so what do? Your first bet in how to mitigate this is to, one, what is in the patient's best interest? You never want to be standing there and saying, well, they have a DNR, but you're withholding life-saving treatments. No one has ever been sued successfully for offering life-sustaining. If somebody is not breathing, okay, breathe for them. The term that I don't know if I coined it. I don't know if I read it somewhere in a classroom sometime, but it's the concept of what's known, especially in cardiac arrest, it is what's known as a slow code. Okay, where we're seeing this more and more now with capnography and everything else like that. But years ago, what we would do is we would start a BLS arrest. We would start treating our patients with BLS. Okay, and just remember, do not resuscitate does not mean you do not treat. What if that patient has just a fever? What if that patient has a UTI? No, that doesn't mean you start you don't start an IV. You do the basic things. There are specific things, so you have to look at each individual. Is it a living will? I do consent to IV therapy. I do not consent to a feeding tube. I do not consent to a breathing tube. So there's individual things in there. The easiest thing for you to do is start treating your patient at the BLS level, and then start working your way through the numbers. Oh, I'm sorry, Mr. or Mrs. Jones. You say you have a DNR. You say, I need that. Can you tell me? Because again, how many patients have you shown up where the DNR is readily available? That's something to think of. Nowadays, we end up having hospice care or end-of-life care where you do have a service that has that all available. Hopefully, you've had someone reach out to you as sort of like a pre-plan and say, hey, my mom's dying. because I've experienced not only the professional side, but also on the personal side where, somebody has a DNR, something like that. The family's there. They're watching grandma or grandpap succumb to the natural mortality, and the family freaks out. So what's the first thing they do? They call 911. Now you're put between a rock and a hard place on what's going. What we're seeing too is a general change in the consensus amongst physicians. 20 years ago, most of the physicians that we worked with deemed a patient dying under their care is unacceptable. You will do everything. You will do everything to save that patient, regardless of what the end is. As the old term was, we would throw everything plus empty the drug box on top of them. So it really starts for you as the clinician to sit, and again, I don't mean physically sit, but try to gather as much information. Hey, I understand you have a DNR. That does not mean do not treat. So you give them a little bit of oxygen. If they look like they're, hypoxic or whatnot, okay, give them a little bag. Maybe CPAP. Maybe they do have a living will that says, I do not want intubated. Okay, what can we do secondary to intubation? Can we put them on a CPAP machine? I'm following their wishes. I'm not intubating them, but I have to treat them in a manner. So EMS is always, unfortunately, drawn into the middle of this. But again, there are the out of hospital, OOH, DNR, the pulsed forms, and everything else that go along with it. I will tell you in 2005-ish, when the pulsed forms, they were called, it was Act 45, Pennsylvania Bureau of EMS, when that started coming out, there were only about 3% of PCPs within the Commonwealth that were even aware that that was out there. That has increased awareness because all of those doctors that were in residency or even went to med school after that, that became something that was known. You have this discussion. In talking about your own mortality is such a taboo discussion. Speaking for, my mom, and later on in the next lecture, I'll show you a picture of my mom 3 days before she died. My sisters, even though they all work in healthcare in some way, shape, or form, were always yelling at me as someone, why are you talking to mom about dying? Well, I want to know what her wishes are. I was my mother's power of attorney and her medical power of attorney. I wanted to know what my mother wanted, to the point of, Mom, what do you want religiously? Do my mother was a Catholic on demand, meaning she only acted Catholic when it, benefited her. And one of the things that she wanted in the morning that she died was she wanted last rites of the Catholic Church. I made sure that that occurred. How did she want laid out? Things like that. What did she want? My mother went out on her own, and that was only after months, years of little discussions on those Sundays when I would make her dinner. Mom, what do you want? If you go at home, what do you want the city of Pittsburgh to do? How do you want them to react when they show up? Well, and her thing was, well, I don't want, she told me, I don't want what happened to your father, which was my father was intubated. My father was put on a ventilator. My father had a hole drilled into his head to relieve the blood filling in his right, cerebral ventricle. She wanted nothing like that. She didn't want intubated, so it was comfort measures only. And that only comes with discussions. We have 20 minutes. Do we have time to do that? Most of the time, you'll find out most of the argument and complaining that comes with families comes from the psychological aspect that somebody has in that family, somebody has undiscussed needs. They can't let go of mom or dad or grandma or grandpa because they haven't said their final words, or they feel that they haven't done anything. Most people that don't want to do something or want everything done ends up having a guilty conscience. I know when we pulled my father, when my father was extubated, and when we decided not to do anything for my mother, that was exactly what they wanted. I used to teach a class on law and ethics, medical law and ethics, that looked at this. Do we truly, at the end of life, looking at and I'm going way too long on this, but this is something that's very, very passionate to me, especially over the last 6 years. Do we, as individuals, have the right to choose when we die? The one thing that we believe we do we actually have that right? I say no, because unless you have, screamed at the mountaintops that you don't want anything done, there's always going to be the Aunt Matilda, my Aunt Sis. There's going to be a pissed off sister or brother or somebody in the family that has an issue with the way somebody is living their life. And that becomes very, very difficult for those individuals that have had that discussion. Dr. Mariachi, who I'll introduce you to, actually has a new project talking about video living wills and having things on people's phones. That's something that's completely new to me, and I'm researching it and the legality behind it. It kind of falls into that same idea about having a tattooed DNR. Is it legal? And I think, for me, a lot of the legality comes in because we're overstepping the lawyer's boundaries and somebody's not getting a retainer fee. Yes, and this is something that we're not going to answer in a lecture, or this is going to be something that you're going to build up with experience. I really, 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 you as the compassionate provider have to take that 35, 40 seconds, treat them BLS, then figure out what's going on. I know that was a very long, BSing idea there, 11 minutes since you asked your question, but it's something that we can always discuss off, and I can give you tons of resources when it comes to that. And I know that's not a hardcore answer, but that's the best that you can do. That's really the best that you can do at that time frame. All right. And then they also have here the abuse side. Please, also, it didn't happen in my family, but please realize that there are documented cases where individuals will keep individuals alive for multiple years, just so they can get their SSI check. If we have time later on, I'll tell you the story about a 90-year-old that they did that I went to court over. Remember high incidence of depression and suicide in the elderly. And honestly, if you think somebody needs to go, I mean, we as clinicians, and I say that we're moving from the technician side over to the clinician side. If you don't think somebody should go, it really doesn't need to go, okay, you can discuss that with them, but never deny them that. Maybe there is some situation where an individual needs to get done and up and out and moved on. But also, if you think they need to go, if there is a threat or imminent danger, treat them. Get the doc on the phone. And I know, this is taboo now, calling medical command, because they're so busy. I'm sorry, ladies and gentlemen, I firmly agree. If there's something that you're not aware of, you're uncomfortable with, you give them a call. Hey, doc, this is what I got. And I told you guys first day, if any of your physicians that you ever call as a student, as a practitioner down the road, if anybody ever has a problem with you giving them a call to ask advice, not something stupid, but ask them advice, and they give you a chew out, you have them call me. I'll go discuss it with them, because one of the tenets of us becoming higher educated individuals is we need to know what we don't know. And the first sign of being a competent clinician is knowing that. I don't know what's going on. Okay, let's call the doc who does. I had an incident with a physician years and years and years ago that chewed me out because I didn't know. And him and I went around and around and around on that. And I told him if he ever got an attitude with me like that on the phone, him and I would have a talk in the backyard. And I know, discussing things physically is not the way to do it. That's just the way I talked 20 years ago. But it's one of those things. We got to have that discussion, and we need them. And if it's what they may deem as silly because they're dealing with 60 patients, we're dealing with one right now. And, we're trying to get them the best care that they deserve at that time. All right. Couple things that you need to have a good working knowledge about, because people are going to ask you, because one of the things people are going to ask is this covered by my insurance? Please note there's Social Security, and there's multiple types of different Social Security as well as VA benefits and everything else like that. You should become a little bit fluid in that. The other thing, one of our largest payers is Medicare, government-based. Remember, even though it is federally backed, each state has the authority to change their Medicare pay rates and everything else like that, because Medicare is dumped down and taken care of at the state level. But Medicare comes in multiple parts. Part A, everybody gets signed up for when they turn 65, or if they have a life-altering event prior to that, which deems them disabled. Part A is you're in hospital care. You have to be admitted, and there's certain rules now. It takes a PhD now to figure that stuff out. If they're readmitted within 30 days for the same signs and symptoms, the hospital does not get paid. That also trickles down to the ambulance service. So that's why we have to do all this paperwork now. When we get to Part B is your out of hospital coverages, outpatient physicians, durable care, overall therapies, durable medical equipment, DME, as well as Part B is where you get my wife's the expert on this, the 180 days of extended care treatment. Remember, Medicare only pays for 180 days. That's it. After that, everything comes out of pocket. And then at that point, you have the 5-year look back financially, where the government, based on your amount of need, if you had a $400,000 house or that amount of assets 1 year ago and you gave it to all your kids, that's why that look back is 5 years ago, because they will judge on your total assets over the past 5 years. So that's something you may hear about, monetary issues down the road. Remember, 95% over the age of 65 are enrolled in Part A, government funded. With that, but again, it's not an infinite till that we can go to. Nearly all are enrolled in Part B, which is voluntary. A lot of people you'll see, if they're still working at age 65, as my dad was. My dad still, he took Part A at 65, but he continued to work for another year until he had his stroke. Maintaining his commercial insurance with his employer, because at the time my mom was going through her second round or third round of lung cancer, and Medicare A and B would have not have paid for anything, but he got full coverage as a county employee. So he ended up staying at work beyond normal retirement age just to cover my mom with the better insurance. As well as what we'll start seeing is what are called, you may see what are known as supplemental benefits. These are all voluntary. You buy them from Highmark, UPMC, Liberty Mutual, all these different things, typically called Part D, but prescription benefits, because there is something in Medicare known as what's known as the donut hole, where once you hit $2,500 of medications to billing Social Security, Medicare kicks in, and then for the next $5,000 you have to pay upfront costs. And then after that, $5,000, which is known as the donut hole, then after that everything is covered by Medicare again, and then that repeats annually. So there is a huge cost to healthcare, even the elderly, when it comes to Medicare, Medicaid, and supplemental insurances. And then we have Medicare, Medicaid. Again, these are for low-income, disabled individuals. Based, I think they have increased the Medicaid numbers from. If anybody knows this number, I can help it. I'm drawing a blank right now, but I think it's 40% below the federal low income, which I believe is for a family of 4 is $23,000 a year. So 40% over that. So add 2,300 to another, $10,000. So for a family of 4, you would have to be making less than $33,000 to gather Medicaid. That's why in Pennsylvania we have CHIP, Children's Health Insurance Programs, for low income individuals or children with long-term care issues up to the age of 18. Kids can get on that regardless of what mom and dad's insurance or financial consideration is. Medicaid is the largest share of public funding for long-term care. You'll hear that term, LTC. About 15 years ago, it was very, very big. We were trying to sell it in the insurance industry. The problem is with the increasing numbers, insurance is like a game. You know, how many people are actually putting in, how many people are actually taking out, comes into Social Security as well. 45% of all financing secondary to Medicaid come for nursing home services. So if you own a nursing home, it's a very lucrative business. That's why a lot of physicians will get into it. Some other insurances that you will see coming down based on the elderly will be the VA. A lot of individuals will tell you, oh, we need transported to the VA because that's what the insurance will pay for. VA has relaxed its emergency procedures as of late because the VA is seeing an overall decrease in the amount of providers. So they allow you to go to the local facility and then they can transport out with that. But again, if you've never got into the VA system, there are different amounts of benefits based on the era in which the veteran has served. If you're a World War II vet, you have a different level of bennies. If you're a Korean War vet, same thing. Same thing with Vietnam eras, as well as now we see the post-1990 Afghanistan, Persian Gulf War, and Afghanistan, everything. We see a new set of VA benefits coming out because despite the fact that, you know, we've had this discussion before on is healthcare a right or a benefit, is it a right or is it a commodity? It's both in the United States. And as we're seeing now, the discussions that we're having now, especially with our decreased call volumes and everything, is how's everything paid for? Because I know none of you right now are coming to paramedic school to go volunteer 100% because nobody will volunteer 100% for their job out of the goodness of their heart. I mean, look what's going on in New York. They're paying people $200 an hour to go up as a nurse and stuff like that. So nobody's doing this stuff for free. As well as in the local government, things that get paid, you know, public hospitals. I know St. Jude's Hospital is a publicly funded care home for the young. Well, there's a large charity hospital in Louisiana, down in New Orleans. Sisters of Mercy in Pittsburgh, I'm aware of now. It's UPMC Mercy. Even though it's a nonprofit UPMC facility, they still maintain their Catholic Charities upbringing, especially with Dr. Withers and everything else like that. A lot of stuff that goes along with that. And we talked about long-term care a little bit, but basically long-term care is a private insurance policy that you purchase as you get life insurance that will hopefully pay down the road. I know under Governor Rendell, they were trying to get a state-funded version of it, and it lasted 3 years, and they just couldn't afford it anymore. As you have seen, hospital has started because of the influx of these elderly individuals. We're starting to see hospitals being shifting patient care back to home. We used to refer to it as the European model 20 years ago. But as I discussed earlier, people want to stay at home. It's cheaper. Insurance doesn't want to pay for it. Regardless of what everybody says, healthcare is a commodity and people want paid for it. That room costs $1,000 a month. So people need to pay for it. So most people, again, don't want to lose their life savings to paying Manor Care or whoever the local flavor is of the year. One of the things that took us in my family with my mom's transition from acute care, which is what we've all been educating ourselves over the past 8-9 months is acute care, is with the geriatric population, we have to start looking at their new normal. They've had multiple disease processes, injuries throughout their life that now alter them and how they present to you. We wish that everything was an emergency, but a lot of times when we deal with geriatrics, it ends up being the new normal. With my mother, as I said, the woman was on 32 liters per minute just to maintain a SAT of 88%. That was secondary to, you know, a lobectomy 15 years prior of her left lung being removed. You know, so hospice while it has taboo connotations to it, hospice allows these terminally ill, not even terminally ill, individuals that have a new norm, that don't benefit by showing up to the ER every 3 days because they have dehydration issues. By declaring and applying for hospice, a whole nother set of doors open up for patients and loved ones. Literally within 4 days of us, and this was a 12-month process of convincing my mom maybe we should consider hospice. And her idea was, you want me to give up? I'm like, no, I want you to continue to live and see your grandkids get married and graduate college. But you have to realize that your COPD, your emphysema, your 40 years of smoking 4 packs a day and drinking, 12 packs a day of alcoholism have led you down a path. You're not the spry 20-year-old that you once were, where you only needed to go to the hospital because you broke your ankle. You need long-term care. You need chronic care. You don't need acute care, which is what the ER was. This woman needed all this oxygen. She needed steroids. She needed anxiety medications because the hypoxia would get to her and she would become anxiety ridden, which would cause her to end up displaying cardiac symptoms. She didn't have a heart attack. She never had a heart problem. She had lung issues and respiratory problems, which caused problems. So there's a transition there, and hospice is one of those things, and there are people that will help. And most of the time, it's actually free to the individual, because what we're trying to find out, especially now, and we'll talk a little bit about community paramedicine and mobile integrated healthcare, we actually start to transition from acute care to chronic care. And that's just a different mindset, where it's okay to need Valium 3 times a day because you're hypoxic. That hypoxic kicks in the hypoxic drive, CO2 goes up, O2 drops into the brain, you're already on tube, but the anxiety gets worse. Cardiac output goes up, heart rate goes up, perhaps the stroke volume doesn't increase, but then that starts feeding the mental issues, the psychological issues, the anxiety. So these are just some, sidebars as you treat your chronic geriatric patients. And again, one of the societal issues that go over is disease and disability later in life are often linked to unhealthy or unsafe behavior early on. Again, this is, the U.S. healthcare versus other individuals, how many people went out and took a walk today at our age? How many people have gone out and, ate a high fiber, lean protein diet versus going to McDonald's drive-through or Burger King drive-through and getting a double Whopper, or something like that. Again, living with my mother over those last several years, we couldn't complain to mom anymore. Guess what, mom? You smoke 4 packs a day of cigarettes for 40 years. We can't fix that. Your life, this is what you have to live with as we move on. And as a provider, we can't become judgmental in that. We just got to take them as they come. I read an article the other day. You signed up by taking this class, by becoming an EMT. You signed up, regardless of whether you like it or not, to take care of all of those patients without regard for their past medical history, without regard for their previous lifestyle. We treat patients regardless. And the whole healthcare system does that as best as we can. One of the best interventions for somebody getting old and geriatric in this is prevention. We go into these houses, we should be doing a safety issue, learning how to do that and whatnot. But also, we found out that as these individuals get older, keeping busy is very, very, very important. And that ties into the whole social aspects, having an animal, stuff like that needs taken care of. Meals on Wheels is one of those social areas that we need to be mindful of. If Meals on Wheels is the only people that see this family and you get a call 3 days later because there's 3 days worth of food in the doorway, maybe something's up. and again, we're being advocates. Those are the ones I always hated, knocking on the doors. Are they laying there? Do we got to bust the door in? These are individuals that have been laying on the floor that are going to be hypothermic, going to be dehydrated, going to be covered in solid and liquid waste, all that other stuff that goes along with those patients. Some other things that you may end up, the societal resources that we can do. Churches are wonderful for coming out and helping people. The state agencies, AARP, the Pennsylvania Department on Aging. And this is where, despite a lot of individuals' reluctancy, a lot of times, as you are young providers, knowing where to get resources, talking about childline, elder abuse, giving good reports to the receiving physicians, nurses, social worker, chaplains, anything else like that that you can give that may be outside of your traditional demissed reports, is honestly fundamental in what we should do with that. Other things, governmental agencies, as we go down, don't forget, there's a lot of work in emergency management when it comes to disasters. What are our elderly people doing now? What about legal representation? What about having PD out there? All of those transportation services, we're seeing, did you guys know that there is a grandparent Uber, just like there's a child Uber? That, as a power of attorney, medical power of attorney, you can set up transportation services. Yes, it costs money with that, but maybe it's something to get grandma up and out, get grandpa up and out, take them to the doctors, take them, when COVID-19's done, get them back to the silver sneakers, walking around the mall or something like that. All of that stuff goes along. And we're seeing this now, and it's becoming embraced with our mobile integrated healthcare systems, community paramedicine that we see locally, going in, helping individuals with their pharmacy needs, their transportation needs, getting mental health needs. We've all had to do these sit down blood pressure screenings and everything else like that, but that's part of being community, being community awareness. One things that you'll have to talk about and become aware of are what is known as ADLs, activities of daily living. As these individuals want to stay home more and more, we have to, when we go in and we start taking care of patients and looking at their needs, especially now that patients don't want to go, family member just called, you have to start being aware of what are called as the ADLs, activities of daily living. Now, the most easiest ones that we can see right away as we come in and do a doorway assessment is, can these patients walk? Can these patients talk? Can they eat, feeding themselves, and can they use the bathroom appropriately without any assistance? This is something that the hospital does when they try to discharge somebody. They look at, those are the top four, but there's a couple other ones that we have to be able to see. When we see these elderly individuals, when we see early warning signs, that may be something that's funky going on. When we go in and take grandma in the hospital because she had a fainting spell or a syncopal episode at the local synagogue or the local house of worship, putting them on the monitor is not a bad thing, because maybe they don't know that they're in new AFib or something like that. It's one of those things, as these individuals are on fixed incomes or they haven't seen their PCP, especially the men, haven't seen their PCP in 10, 15 years, maybe that's their only chance of finding out what's going on. So again, from day one, we said every patient deserves a full assessment. Your skills are expanded, put a monitor on. There's absolutely nothing wrong with that, to find out, just to rule out, is there anything else wrong? And again, just because they're having certain signs and symptoms doesn't mean that it's pointing to an underlying cause of problem or illness. Most elderly patients have an underlying chronic condition of at least 6 different conditions working at once. Some may be undiagnosed. So again, it's not the acute manifestation, it is the roll up on all of these multiple chronic conditions. And this may become a new normal for them. Whatever it is. And one of the hardest things growing older is realizing that you're not as young as you used to be. Some other ADLs I want to just expand on when we start looking at stuff. Can patients walk? The term for this is ambulating. This is one of those things that you guys have to document on your PCRs, physician care narratives. Is can the patient ambulate? If the patient can walk, the chances of them just needing a ride to the hospital, Medicare isn't going to pay for that. But if they're ambulating with assistance, if they're ambulating assistance with it and you're giving them an O2 treatment, you're giving them a nebulizer. I'm sorry, I know that's taboo now, but if you got them on the monitor or something like that, that's very important. But again, can they walk appropriately? Do they need, possibly they can walk, but do they need a cane or do they need a walker? Are they feeding? Are they, again, not so much cooking, but are they able to feed themselves normal? Do they need pureed food? Do they need handles? Do they need special adaptive spoons and or forks? Can they dress and groom themselves? Yes, that means can they take a shower? And I think the average ADL is a shower or a bath every 2 days. With that, are they able to toilet? And again, that's solid and liquid waste. Think about it. How would you feel if you couldn't go to the bathroom yourself? How would you feel if you couldn't clean yourself after utilizing the facilities? That's something is an ADL that may require modification. Perhaps now we're talking about bidets, and again, the bathing and everything goes into that as well. And then again, this kind of goes along with the walking. Can they transfer? Can they live in a wheelchair, move themselves around with some modifications of their house? Can they get in and out of bed on their own? Can they move from the toilet? How many of you have walked into a patient's house where they've had the potty chair sitting in the kitchen or in the dining room, or next to the bed? My mother had 3 of them. One in the living room, one in a modified one in the bathroom, and then one in the bedroom. For the last 6 months of her life, my mom didn't go to her bedroom anymore. And it became too hard for her to transverse the 18 feet from her chair to the bathroom. So we would lift her up and sit her down. And then ultimately, towards the end there, it was into adult diapers, but it was living up to her wishes that she didn't want to go. And I quote, "I'm not going to no damn nursing home." Okay, Mom. So the pathophysiology, the changing from the idea of what is acute to chronic, we have to look at, the complexities of the elderly. One, they suffer more than one illness or one disease at a time. On average, 6 medical diseases. All right. And that doesn't include, I've got some interesting statistics when we look at hip fractures. And again, because everything is connected, even though we learn all about the individual systems standalone, please realize that one organ system the disease state can result in overall deterioration of other systems. And again, complaints just may not be specific to any one disorder as we move along. Common signs and symptoms when we look at our patients, it's literally everything that we've been discussing over the past year. Fatigue and weakness. I don't feel well. Well, what can be causing that? Well, I'm sick. Okay, how are you sick? Do I have a fever? Okay, have I had diarrhea? Okay. I get dizziness. I get vertigo. I have syncopal episodes which lead to falls, trauma. I have headaches. Well, is that related to dehydration, or is it related to COVID or to the flu, or something like that? Insomnia. You would be amazed, and I hope some of you have experienced this with your, if you have grandmas and grandpas, on how little they actually sleep, or not that they sleep little, is they sleep at inopportune times when our sleep cycle is. I know my mother would be up all night, as well as my wife's grandmother would call her at 3 to 5 o'clock in the morning and talk with her. And she goes, "Oh, I can't sleep, dear." "Oh, no, that's because you sleep, from noon to 5 every day." So their circadian rhythms get off. They suffer from dysphagia, which is inability to swallow, which then can lead loss of appetite, as well as inability to void, either solid or liquid. And because of different medications and everything else like that, they can end up suffering from overall constipation and diarrhea. That's why we'll see later when we look at assessing these patients, asking someone are they constipated, or when was their last bowel movement, is not so funny, because that can lead to so much more issues. And again, everything changes. Person 65 and older, this is an interesting number, but please realize this is across our society of the elderly. Person 65 and older use 1/3 of all prescription drugs in the US. That means that when you show up on a patient, on average, they're going to take 4.5 medications per day. And that doesn't include your over-the-counters. How many patients have you ever gone to that have, St. John's wort, that have taken, essential oils, or, look at the elderly male. Once you hit a certain age in life, the taboo aspect of getting older was no longer having sex. Thanks to phosphodiesterase, sildenafils, your blue chews, your Viagra, Cialis, and all that other stuff, individuals are now having sex later on into their geriatric life. One of the biggest infectious diseases that one of the largest areas for that, an STD, gonorrhea, outside of the prison system, is nursing homes. Because with these drugs now, we have individuals that are able to have sex. I think, and I don't know if I told you the story, but there was a nursing home in my primary service area where there used to be a woman who would run, an elderly woman who ran a brothel in the nursing home, and she would sell Viagra to her male counterparts, and she had a brothel of women that would take care of the elderly male clients. And this was 65 and older. It was pretty interesting. We also have with the elderly, it's kind of, and again, I don't know if it's reduced, especially now with electronic PCRs and EHRs and electronic prescriptions, but we do have a large aspect of what's called polypharmacy with the elderly, where people will store things, they won't take things, but what they can do is they'll go around. There is a big black market of elderly individuals sharing drugs. Somebody has a disease and they get a certain drug. Well, Margaret doesn't get it, but Emma does. So Emma will sell Margaret her OxyContins or something like that. My wife's grandmother, when Bob died, we had counted probably, I don't know, if you were to say that you got OxyContin 500 milligrams, Tylenol, and I forget what the OC was, she had enough for almost 900 days of taking OC 3 times a day. But this again was before the opioid epidemic. She not only had liquid, but she also had pills. So there is a black market, but again, we end up getting this concept of what's called polypharmacy, where we get multiple drugs by a single patient for one or more conditions. I used to take care of an elderly neighbor, and we would go see 5 different physicians in 2 or 3 days, and each physician would give different, the same prescription over that week for the same treatment. We go see her PCP, then we go see her gerontologist, then we go see her cardiovascular, her GI, and they'd all give her all the same medicines. So this woman would walk out with, instead of a 30-day supply, she'd end up walking up with 5 different 30-day supplies of the same drug. And so with that, you can see that there is a lot of possibility of overdoses with that. As well as, because of that polypharmacy, we end up getting multiple drug interactions. And it's very important that, again, we need to figure out what those meds are. One, to make sure that they're taking them, but also to make sure that they're not taking too many, or making sure that they are taking them, because, again, some of these individuals are on fixed incomes, and they may don't take them as prescribed, which is an issue down the road. And because of this decrease, why do they do this decreased drug compliance? Well, 1, limited income. 2, memory loss. I forgot. I didn't do this. They didn't have a caretaker. They didn't set up their drug box or whatever. They can't reach where the family member put their drugs, or they have limited mobility. They have poor sensory impairment. They can't tell or not they swallowed, the dysphagia. So therefore, they don't feel comfortable taking it because they don't want to choke. They don't want to aspirate. Multiple or complicated drug therapies, especially when you start getting into cancer treatments, you have to take them on a daily schedule. This is a lot where CP comes into. The fear of overdosing, the fear of the toxicity. I don't know what I'm going to do. What happens if we give individuals with childproof containers? And how long does the drug therapy last? Because again, it is a financial consideration along with that. Now, things that again increase drug compliance: good patient physician communication. This is where your mobile integrated healthcare and your cardiac community paramedic comes in. Individuals are also more compliant with their medications when they believe that the illness or the injury is more serious. We give them sticker charts, drug cards, drug reminders, or we give them something that's easier to open. And again, those blister packs that move along with that. And here we could just see a general more common blister packs up here versus the harder to open childlike. Now, some of you have seen, this is an older picture, but some of them have come up with some very unique ways to open this stuff and flip. They can flip them over, larger stuff when it comes to that. But it's just basically a idea of getting access to stuff. So Andy just walked in. It is